everyone. Can you hear me well?
I can hear you.
Then you can hear me, or
We can hear you a lot.
I cannot. You can hear me? Perfect. Oh, great. Okay. I cannot hear anyone, but it's okay. I just wanted to ask some questions during the. Yeah, go ahead. Mhm. Can anybody tell me if they can hear me?
We can hear
Yes,
you.
we can hear you.
Okay, hopefully that's the case. All right. Thank you, Dan. Good morning, everyone, and sorry for the technical difficulties. So I'll be talking to you today about smoking-related interstitial lung disease. We'll try make it as interactive as possible. Little of a dry subject, but we'll try hopefully our best to make it interesting. Of course, no financial disclosure. So today we'll be talking about the classifications of interstitial lung diseases quickly in general. And among that, we'll talk about smoking-related ILD, prevalence of the disease, pathogenesis, focus on radiology and pathology with, of course, treatment outcomes and prognosis. We'll mainly talk about respiratory bronchiolitis, ILD, Desquamative interstitial pneumonia, ELCH, and smoking-related interstitial fibrosis. We'll talk about some other diseases where there is a kind of a straight relation with smoking among the acute and chronic settings of diffuse parenchymal lung diseases. Is smoking on a decline throughout the world? Definitely not in the developing countries, mainly more in the developed world, and some statistics from the United States in the last 10 years. You can see where the situated smoking up to 26% in some states compared to others. Male more than female, I think it's more in the developed world more than the developing world. And of course, this is a report from 2016, more than 440,000 US deaths were attributed to reasons straightly related to smoking cigarettes, including lung cancer, ischemic heart disease, COPD with complications, among others. Here is a report from the New England Journal of Medicine in 2013, which actually reported the life expectancy of patients, of smokers compared to non-smokers, where it showed the shortening of almost 10 years between smokers and non-smokers, and a threefold increase in the rate of death among patients who smoked compared to non-smokers due to the reasons we just mentioned. With that, I'm going to start with the interstitial lung diseases classification. And to those who did the rotation with us, we already went through this classification to try simplify the forms of interstitial lung diseases into the chronicity of the disease, the behavior of the disease, and the response to therapy. In addition, of course, to the pathophysiology. So as you see in this slide, so we have diffuse parenchymal lung diseases due to a specific reason, whether it's a drug or a systemic disease. We have the idiopathic forms of interstitial pneumonias, and under which IPF is a main category, but there, among others, of idiopathic pulmonary fibroses that we will go through this talk, where you will see 3 or 4 of them straightly related to smoking. In the big categories, there is a granulomatous diffuse parenchymal lung disease, and top of the list is sarcoidosis, but also vasculitis especially with polyangiitis comes under this category. And there are the other rare forms of diffuse parenchymal lung disease that we will not shed light on today. But the specific 4 diagnoses straightly related to smoking that we will talk about today are what I already mentioned: RB-ILD, DIP, pulmonary Langerhans cell histiocytosis, the limited form, the pulmonary disease, and the SRIF, or smoking-related interstitial fibrosis. And as I told you, the classifications for pulmonary fibrosis can walk through the chronicity of the disease, so chronic versus acute, and smoking-related as a unique entity. And you can here have an idea about the radiopathologic patterns with the clinical diagnosis on the right column. I'll go through this slide like in the conclusion of this talk later on, but it will not have the diseases that are not strictly related to smoking, so I'll bear on this slide for now. As I mentioned, so other than smoking being straightly related to these 4 categories of interstitial lung diseases, smoking is, as we all know, is straightly related to the morbidity and mortality of COPD. Previous history of smoking is one of the main risk factors in development of IPF and CPFE. And in the acute setting, there is a straight relation between acute eosinophilic pneumonia and smoking, whether it's cigarettes or other inhalants. And also there is a straight relation between smoking and what is known as the Good-Basters syndrome, or anti-GPM vasculitis. In IPF, why IPF is not mentioned as a disease straightly related to smoking? It's actually yes, there is a risk or a history of active or former smoking that is almost twofold in patients with IPF compared to those who don't develop the disease. But not every patient with IPF have smoked before. So there is a 1.6 times greater risk of developing IPF in smokers compared to non-smokers. But there are many patients with IPF who never smoked. As we know, IPF is almost 2 per 100,000 adults in the US. And here I wanted also to mention in this slide that having active smoking in patients with IPF, as you may have seen in our clinic, precludes the patient or disqualifies them from the disease-specific therapies that are recently FDA approved with antifibrotics. So patients have to stop smoking before they can qualify for the therapy. Another example of where smoking also interacts with directly with the disease course is in rheumatoid arthritis-related ILD, and here's a slide that shows the difference between rheumatoid arthritis UIP pattern compared to rheumatoid arthritis interstitial lung disease, but with a non-UIP pattern. The UIP pattern, of course, is the form that is poorly responsive to therapy, worse outcome, and it's mainly in male previous smoker. So older male previous smoker is the demographics of patients of RA UIP. which is very similar to the demographics we know about the typical IPF patient. It's also straightly correlated with previous history of smoking. And as I mentioned, acute eosinophilic pneumonia, if you go through the causes of acute eosinophilic pneumonia, you will find in the first category many of the inhalants, acute inhalation, whether it's cigarette smoking, resumption of cigarette smoking, secondhand cigarette smoking, electrolyte cigarette, with of course the recent pandemic of vaping that everybody witnessed prior to the COVID pandemic. In addition, many of us, including some of our attendings, have observed and treated patients with acute eosinophilic pneumonia secondary to multiple inhalants, including hookah, cigarettes, electronic cigarettes, among others. Smoking-related ILDs are not very common. So here in this slide, which is one of the excellent review articles for IPF from 2018 in any AGM by this was an estimate of the distribution of ILDs in the United States. 20% for connective tissue disease related ILD, sarcoidosis, chronic hypersensitivity, and IPF, and 10% distribution for other ILDs, among which is the smoking related lung disease. So the rare entity in ILD. To know the prevalence of the interstitial changes in the community, I found this paper published in 2011 in the New England Journal of Medicine. This is a study where 2,508 patients were reviewed between November 2007 and April 2010. So smokers, and the race was white, as well as Black population, 74% white and 26% Black, between the age of 45 and 80, who had at least 10 years smoking history. And these patients were observed in the GOLD guidelines for COPD, including the physiologic assessment with spirodiffusion, questionnaire about symptoms, and etc., was applied to all these patients, in addition to qualitative and quantitative high-resolution CAT scan. And each of these CAT scans was reviewed by 3 readers. So I'll review with you the results of this observation to have an idea about the prevalence of smoking-related ILD among this big cohort of 2,500 patients. So here in this slide, they mentioned a couple of categories of interstitial opacities on the CAT scans. I want you to walk with me through the right columns first and look into the first row up till the 4th row. So we'll go through non-dependent ground class opacities, reticular opacities, centrolobular nodularity here, in addition to some centrolobular nodularity in here, cysts, if they are observed, presence of honeycombing, yes or no, and traction bronchiectasis, as you see in this last column. So 6 categories of interstitial opacities that suggest the presence of an ILD. And they separated the patients into patients who have GOLD classification for COPD. So GOLD classification stage 0 or 1, GOLD classification stage 2 and 4. And as you see, majority of the patients, 800 plus 600, met the criteria for GOLD for COPD. And there is 131 patients who did not qualify. And in each of these categories, they saw how many of the patients had interstitial lung abnormalities. So 1 or more of the 6 categories I already mentioned to you in the previous slide. They also had a correlation between, so where does the patient fit in the COPD categories between 0 and 4. And they observed what's the prevalence of interstitial lung abnormalities in these patients. And the findings were interesting. So if I walk through the previous slide here, so the translucent yellow here or greenish represents the normal lung parenchyma. The white represents the airways. The opaque orange represents the subpleural abnormalities in the patients. And you can tell between this CAT scan and this CAT scan how much of interstitial opacity is observed in these patients. So what is found is actually the total lung capacity was normal in the patients, of course, who did not qualify for gold, but those are the patients who had the main prevalence of interstitial opacities or interstitial lung abnormalities. So 22% of the patients who did not meet gold criteria had ILD, compared to 13% who had early stage COPD, compared to 10% of patients who had a stage 2 to 4 COPD. And the most common radiologic pattern that is suggestive of interstitial lung disease was the poorly differentiated central-lobular ground glass or nodule. And the least was the presence of honeycombing in these patients. And as I said here in this slide, you can tell the presence of these abnormalities most common to the least common. And the more advanced is the patient in their COPD, the less likely it is for them to have associated interstitial lung abnormalities. We'll walk through each of these categories through the diagnosis, through the HRCT, but I'll mention here about the BAL. The BAL can be helpful in ruling out other diseases when approaching smoking-related interstitial lung diseases, mainly to rule out the presence of lymphocytes or eosinophils, especially in the acute setting, but lymphocytes for the consideration of hypersensitivity pneumonia. Transbronchial biopsies might be indicated in specific scenarios, as well as surgical lung biopsy in case of clinical worsening without a definite diagnosis. We'll go through that in the 4 or 5 categories that we'll talk about. And why do we need to early detect these diseases? First of all is to mainly diagnose diseases where new FDA approved therapies have come to surface, and specifically talking about IPF and CPFE with the antifibrotics, but also we can use the antifibrotics for any progressive fibrosing lung disease, and we'll talk about in which of these categories they can be used. In addition, there is the detection of the diseases with close monitoring in the future for the need for early referral for lung transplant eval. And as I mentioned, the diseases where you can drastically change the prognosis of patients by smoking cessation, it's worth knowing about the diagnosis to aggressively work with patients on smoking cessation. So far, any questions? All right, I'm sorry, I don't think I can hear anybody, and that's going to be a problem because I wanted to have this as an interactive session. Okay. Talking about the pathophysiology of pulmonary fibrosis in smoking-related interstitial lung diseases, as you see in this slide, there are many risk factors for the development of interstitial lung disease, from age to genetic factors that we will go through, to the environmental exposure, in addition to inhalation risk factors. Inflammation and fibrosis side by side with diseases that have predominantly fibrosis with very mild inflammation compared to others, where the opposite is observed. I borrowed this slide from the IPF review paper that I told you about, to go through the history of pulmonary fibrosis in general. And I want you to bear with me on this slide. So you have an environmental risk factor on top of the list, of course, always will be smoking, but among others. Before I go, I want to refresh our memories about two components of the lung parenchyma: the endothelium inside the alveoli, the epithelium inside the alveoli, and the endothelium in the interstitium. And the interaction between these two is what will be vital to understand the pathogenesis of pulmonary fibrosis. So an inhalation will be coming from the outside into the lining of the epithelium, mainly alveolar type 1 cells. As you know, 95% of the epithelium is type 1. And any injury to the epithelium will generate the work of the alveolar stem cells, or the alveolar type 2 epithelial cells. And these cells will work on the repair of the epithelium for any injury. The senescence and the apoptosis of the type 2 cell is what is naturally happening when it does the job, and it changes or repairs the area of injury into a type 1 alveolar epithelial cell again. But the malfunctioning of the apoptosis of the type 2 cell, which we will go through the reasons for it, can form the myelofibroblasts. And the injury part of the lung that was repaired, macrophages have to come to help in the repair. And the activation of the macrophages with some agents might develop or turn over develop a malformed matrix. And the interaction between a malformed matrix and the development of myofibroblasts, which will change into fibroblasts, will cause the fibroblastic foci in IPF, but will also be the initial event for the development of fibrosis in the endothelium in the lung. So that's in brief about how smoking can be interacting with lung fibrosis. The senescence of these type 2 cells, when would it be malformed? Mainly when patients have, for example, shortened telomeres or abnormal telomeres in the lung. And we talked about that extensively in IPF with extensive studying about that, but it also is questionable to be part of the fibrosis in many other diseases other than IPF. So again, smoking not only is the initial inhalation injury to the epithelium, but also smoking cigarettes can trigger and induce some factors that are essential for the generation of the matrix, as we mentioned in the previous slides. And mainly, we're talking about the growth factor and the platelet-derived, growth factor and the platelet-derived growth factors. And again, it's essential in the generation of the matrix that will be part of the fibrosis formation in the endothelium. So the first category or the first disease we'll talk about is respiratory bronchiolitis, ILD. Differentiated from respiratory bronchiolitis, So the definition of respiratory bronchiolitis is mainly the deposition of these pigmented macrophages in the respiratory alveoli in the peribronchoalveolar spaces. But RBILD is the respiratory bronchiolitis associated with smoking, and I'll mention why we differentiate the two. Usually patients have a smoking history of between 10 and 30 years. The recovery time to heal from the disease is established between any time between 1 and 30 years. And that wide ranges because of whether or not patients developed any peribronchial fibrosis. Usually patients are minimally symptomatic. I will mention about the radiologic patterns. So the most common radiologic pattern in these patients is poorly differentiated centrilobular ground class opacities or nodules. But the most common actually radiologic pattern is just bronchial wall thickening in these patients in 90% of the patients. 71% of the patients will have these poorly differentiated ground class opacities or nodules. The histopathology of the disease, I actually put you here a slide, and this is where I was hoping for interaction with the team. Unfortunately, I'm unable to, so you guys are saved. So here is a normal slide for a normal lung tissue, and you can see here respiratory bronchial surrounded by the smooth muscles, lined by the epithelium. And here you can see the normal healthy alveoli with a very thin alveolar septae, no inflammation, no thickening, normal lung. In here, you can see how the respiratory bronchioles are filled with macrophages. And in addition, you can see around the bronchioles, how the inflammation and the filling of the alveoli just around this respiratory bronchiole is filled with the macrophages as well. You still can observe normal alveoli outside that area of inflammation. And of course, the CAT scan will show you these poorly differentiated centrilobular nodules. Here is a different differentiation. I'm hopeful to make it clear between what respiratory bronchiolitis ILD looks like compared to the next category that we will talk about, which is the desquamative interstitial pneumonia. Again, normal lung, normal alveolar septum in here, normal alveolar septum in the areas outside the respiratory bronchioles in RBILD, with macrophages filling the respiratory bronchioles and the alveoli just around it. But look at what happens in DIP. So you have intraalveolar macrophages, and look at the septum between these alveoli. It's thickened and has fibrosis. And that's what differentiates DIP from RBILD. Of course, the treatment of the disease is smoking cessation is number one. Usually, prognosis is good, with some exceptions, especially from some reviews in the literature when peribronchial fibrosis is present. So there are cases of further deterioration of the disease even after smoking cessation, but that's not the norm. In symptomatic patients, steroids have been used with and can only or recommended only to be used with significant functional. I'll move to the next category, which is DIP. Desquamative interstitial pneumonia is one of the rarest diseases in ILD. And the name desquamative interstitial pneumonia comes from the thinking of desquamation in the epithelial cells, first described in 1965. But we learned right now that the histopathology is not the desquamation of epithelial cells. Actually, it's the abnormal collection of the cells in the alveolar space and accumulation of the macrophages rather than being a desquamation of the epithelial cells. Usually that is called the smoker's macrophages. In addition, these patients will have some lymphoid nodules Most cases of DIP are caused by cigarette smoking, up to 90% of the patients. Physiologic impairment is way more observed than compared to RB-ILD with limitations to daily activity. And we will talk about smoking-related DIP compared to DIP, or what we call DIP-like reaction found in non-smokers in a second. Radiologically, you can observe in these patients on high-resolution CAT scan the increased ground glass opacities in a geographic pattern in the lung, central more than peripheral, with relatively sparing of the subpleura, with a reticular pattern in these areas, so not pure ground glass opacity, but there is reticular pattern in a geographic distribution, not subpleural in these cases. I think, yeah, I mentioned I here have another example of an advanced case of DIP, and you can see the geographic distribution of the fibrosis, very similar to what you may see in IPF. The clinical course and the relative stability of the disease through many years, when you see them in this advanced stage of disease, is what differentiates them from IPF, in addition to the way less impairment of their physiology and functional status compared to IPF patients, talking mainly about PFTs and DLCO. The histopathology, we already went through it with RB-ILD, but I'm happy to walk you again through this slide. So you have the alveolar smokers macrophages with the thickened alveolar septum and presence of fibrosis. I think we already went through this one. Now, I wanted to ask everyone, and maybe I can ask you to put in a chat box. In the chat box, if you don't mind, guys, what do you see about this slide? And this is none of what we have already mentioned. What does this slide represent for those who just got the boards recently? Okay. I'm sorry, it's not gonna work, looks like. Let's see, yeah, chat. Perfect. So Guazdala is the winner. This is COPD, and the reason is there is a respiratory bronchial, there are normal alveoli with alveolar septum, but there is just the presence of emphysema. That's all in this slide. No inflammation, no intra-alveolar septal thickening or fibrosis. Good, excellent. What about the down slide, A, B, and C? Any takers in the chat box? I'll buy him a coffee then. All right, excellent. Thank you, Dr. Domingo. So we have subpleural distribution of a disease that doesn't start from inside the airways or peribronchial, but it starts from the pleura, skipped lesions in the in this category. When we go more closer, you will have the typical fibroplastic foci in the interstitium, and that represents the typical UIP pattern. So this is UIP. And when I go in histopathology again to DIP, you can see the difference. And this is maybe what I want to emphasize on. So the main thing that differentiates DIP from UIP is the lack or the rarity of fibroplastic foci. And the interstitial fibrosis and inflammation with the presence of the macrophages in the alveolar spaces. And of course, not hemosiderin macrophages, but you may have presence of iron in these macrophages. All right. Is there any relation to NSIP? And I put that slide in here because actually, if you take the intraalveolar macrophages from the slides of DIP, then it looks very much like fibrotic NSIP. And that is an interesting question in literature, especially when we talk about the DIP-like reaction. However, the outcome of DIP is way different and better than the outcome of NSIP. So the associations of DIP-like reaction that literature, and some of you have worked, actually 2 of you have worked with me on DIP-like reaction case reports in the hospital, but we did see DIP in connective tissue diseases, especially in rheumatoid arthritis. We reported a case of hepatitis C-induced DIP. There are drugs that can cause a DIP-like reaction, among other systemic diseases. In the transplant literature, the presence of DIP or DIP-like reaction pre-transplant have been a risk factor for development of DIP in the transplanted lung. And actually, we had a case here at Henry Ford that also was reported. Wide differential for DIP, especially after you see that relation to NSIP. But the smoking-related DIP is what we're going to emphasize and talk about here. So the survival of DIP in smoking-related DIP in the literature is actually excellent. And there are multiple reports from literature that shows a survival between 70 and 94%. This study from 2005 compared the outcome between RB, ILD, and DIP, and I'll actually skip this one for the sake of time because we talked about it. I'll go through the mortality of DIP. So up to 26% of patients may have mortality. The progression of the disease happens in 2/3 of the time. With the possibility of disease limiting itself in the other 2/3. Treatment of the disease, steroids can be used in progressive disease. Steroid-sparing agents are used only in case report basis, but the progression of the disease may warrant evaluation for lung transplant. And right now, with the progression of fibrosis, if evaluated early on, again, we can use the antifibrotics for progressive fibrosing interstitial lung disease. The last category I'll talk about today is the PLCH, and we'll talk about the pulmonary PLCH. So it's one of the unusual respiratory diseases, mostly found in young adults, 3rd to 4th decade, rarely in children. When we talk about, again, about the pulmonary PLCH, not the disseminated LCH. 95% of the patients are smokers. And it's estimated that the disease might be found in as much as 4% of all smokers. It's actually affecting both genders equally, and the symptoms usually are vague, of weight loss, exertional dyspnea, and fatigue. But interestingly, up to 15 to 20% of the patients might have spontaneous pneumothorax as the first sign of their disease. The pathophysiology of the disease is interesting, and I actually prepared you this slide. One of them is taken from a paper about IPF, and the other one is straightly related to PLCH. But basically, on the left side here, the epithelial injury and with the old cascade that we mentioned about the development of fibrosis is in this paper. But I put this paper here to talk about the osteopontins. The osteopontin is an activator to the tyrosine kinases and might actually, it might enhance the the accumulation of the Langerhans cells, and it's one of the main pathophysiologies of the development or of the accumulation of the Langerhans cells around the airways, to have the deposition that will change into nodules, and further in the disease will activate the fibrotic process in the endothelium. And in the late stages of the disease, you will start having the cystic formation of the disease. One of the unique entities in smoking-related ILDs, where it starts with a restrictive lung physiology, minimal symptoms, and in the advanced stages of the disease changes into the obstructive pattern, late cystic disease due to that physiology. Here is the radiology of the advanced disease with multiple cysts, usually less than 1 centimeter in size, bronchial wall thickening, centrolobular nodules is what you see. And later in the stages of disease, you will have the predominance of the cystic lung disease. The pathophysiology, actually, we went through it already. Treatment-wise, usually PLCH carries a good prognosis in the early stages. In the late stages of the disease, pulmonary hypertension may be observed in up to 75% of the patients, and the referral to lung transplant will be the way to go in that situation. Treatment in the early stages of the disease is with steroids, and if steroid dependent, can use the immunosuppressive therapy. Imuran is being used, but I found in the literature the use of cladribine is one of the purine analogs that induces apoptosis in the lymphocytes and the monocytes, and then has the immunosuppressive effect in these cases. Now, in the systemic disease, we will not be reviewing the treatments for the systemic disease, but there are definitely treatments that are observed in these cases. And again, I mentioned lung transplant will be early referral to lung transplant, especially with the development of PH, is warranted. The last category I'm going to talk about is smoking-related interstitial fibrosis. You will find it under other names in the literature, like the airspace enlargement with fibrosis, AEF. This disease usually is found incidentally in case reports in the literature, with an average age of 65, usually current or previous smokers, up to 40 pack year, again with no gender predominance, and it's one of the vague interstitial lung diseases with an unclear radiologic features, but we'll go through some recent publications regarding SRIF. Here, really a good paper from China in 2016. They had 65 patients who underwent lung biopsy for the suspicion of UIP, depending on an HRCT pattern. And then after the radiologic pathologic correlation, these patients were divided into three groups. One group with a UIP pathology, one group with CPFE, so UIP with emphysema, and one group with smoking-related interstitial fibrosis. And I'll walk you through that. They had a scoring of the HRCT between 0 and 4, so six categories. And they had a scoring, sorry, for emphysema, six categories for emphysema in the top row, and 5 scoring systems for fibrosis in the lower row. And what they did, actually, they defined again qualitatively on the HRCT. They defined 6 components of of a fibrotic change in the lung. So asymmetry of the changes between the two lung fields, subpleural sparing that you can observe in here that does not correlate with UIP, emphysema in areas next to honeycombing areas, ground class opacities and reticulation in the areas of honeycombing. So honeycombing adjacent to it, some ground class opacities and reticulation. Homogeneity of the honeycombing. This is something that you might have observed in many of the cases we reviewed here in the clinic. And honeycombing if present in the upper lobes. So they define these 6 categories or signs as not indicative of UIP. And what they found is in their analysis, they found that the pathologic and radiologic diagnosis, or mainly the pathologic diagnosis of smoking-related IF, was observed in the patients who had 3 or more of these changes, radiologic changes. So 6 signs that shift you away from ITF. They found if patients have 3 or more, then their diagnosis is more likely to be SRIF compared to UIP. And what is the importance of observing that is that patients with SRIF have 5-year survival of almost 85%. So the disease behavior is way different than UIP. So they found if you have 3 or more of these categories, then the patients had SRIF, and they found the extent of emphysema in the patients with smoking-related interstitial fibrosis to be way higher compared to the patients who had UIP. The pathology of the disease, as you can see, you have fibrosis in the alveolar spaces, and subpleural and peribronchial distribution. And the main thing about this disease is that preserves the lung architecture. So here is a normal lung architecture, but with alveolar space fibrosis. And that's what mainly differentiates it from UIP. Again, here you can see, actually, I can use the I can tell you here where the fibrosis of these alveoli is actually confined to the subpleural area, and you can see in the left image here where there is also some emphysema components in addition to the alveolar space fibrosis, but the architecture is still preserved. On the right side, you can see how there is these atypical cells with collagen deposition, and it gives this shape entrapped hyperplastic smooth muscle bundles, one of the pathognomonic findings in SRIF. Of course, as many of the smoking-related lung diseases, it can be correlated with or associated with respiratory bronchiolitis in these cases. In the chat box, if you wanna, can you write me what you think is this left side is after what we talked about, and especially with the presence of this component in the subpleural, in the endothelium. So for the sake of time, I'll just go ahead and this is the fibroblastic foci indicative of UIP compared to the smooth fibrosis and alveolar thickening with preserved lung architecture of SRIF. And I think in here I mentioned to you an example between SRIF down in the screen compared to the very similar appearance, but with the presence of lymphocyte predominant inflammation. So thickening and lymphocyte predominant inflammation of the alveolar spaces in a diffuse pattern. This represents NSIP. So that's one of the main differences between SRIF and NSIP pathologically. So again, in this slide, I just wanted to show you the difference in pathology, radiology, and even the disease course and the prognosis. And with that, I'm gonna leave you with this slide for your review that talks about the demographics of these diseases, the symptoms, the PFTs, and especially when patients in PLCH go from restrictive to obstructive pattern, as we talked about, the radiologic patterns, and the key management strategies used in these diseases. Please, if you have any questions, put it in the chat box or email me. And I thank everybody for listening.